To our webinar today for the STN Marketing Committee. Also remind you that today's session is being recorded so that it can be offered as an on-demand webinar at a later time. Your lines are muted, however, you do have an opportunity to ask questions. If you will look on the control panel, you can type in your question at any time. If we have time at the end, we will be able to take questions. This webinar is going to offer one contact hour. If you're viewing this as on demand, that contact hours will expire in 2016. To complete the CE for this session, you must complete the evaluation at the end of the survey. About an hour after this survey, you will receive an email with a link in it to complete the evaluation. Once you complete the evaluation, be sure to include your name as you want it to appear on your certificate and an email address for your certificate to be emailed to. If you have any questions or concerns, feel free to contact STN headquarters. And now that I'm finished with announcements, it's my pleasure to introduce today's speaker, Dr. Stephen Gambert. Dr. Gambert is a tenured professor of medicine and surgery at the University of Maryland School of Medicine, where he is an associate chairman of the Department of Medicine and director of geriatrics at the University of Maryland Medical Center and interim director of the Division of Gerontology and Geriatric Medicine at the Medical School. He is director of the Geriatric Service at R. Adams Cowley Shock Trauma Center and is director of medical student programs for the Department of Medicine, director of the third-year medicine clerkship, and co-course director of the Introduction to Clinical Medical course for second-year students. Prior to joining the faculty at the University of Maryland, Dr. Gambert was professor of medicine at Johns Hopkins University School of Medicine and chairman of the Department of Medicine at Sinai Hospital of Baltimore, where he was also the residency program director of the Johns Hopkins University Sinai Hospital Residency Program in Internal Medicine. Prior to this, he was vice chairman for academic affairs and professor of medicine at UMDNJ, New Jersey Medical School, professor of medicine and acting chairman of medicine at the New York Medical College, where he was also associate dean for academic programs. A graduate of Columbia University College of Physicians and Surgeons, he received postgraduate training at Dartmouth and Harvard Medical Schools, where he specialized in internal medicine, endocrinology and metabolism, and gerontology and geriatric medicine. He has co-authored over 400 journal articles, book chapters, and research reports, been editor of numerous publications, and served on many editorial boards. He has been president of the American Aging Association, chairman of clinical medicine for the Gerontological Society, president of the Baltimore City Medical Society, and governor of the New York State chapter of the American College of Physicians, among other leadership roles. He has been a recipient of the Geriatric Medicine Academic Award of National Institute on Aging, the Joseph T. Freeman Award of the Gerontological Society of America, the Laureate Award of the American College of Physicians. He has served as a member of the National Board of Medical Examiners, USMLE Step 3 Committee, and has consistently been recognized as one of America's best physicians. He was elected to mastership in the American College of Physicians, its highest honor. Dr. Gambert?
Well, thank you very much. I appreciate that very nice invitation and wonderful introduction. First of all, I have nothing to claim or disclose, as it says on this slide here. And I'm going to present to you today a very unique aspect to trauma care in the elderly, and that most people have contact with surgical faculty. And although I'm in the Department of Surgery as a secondary appointment, I'm an internal medicine physician and, most importantly, a geriatrician. Trauma is the 7th leading cause of death in Americans older than age 65. But it's important to note that elderly who are injured have much more severe problems, more likely to have comorbidities entering into the hospital, and suffer more complications from their traumatic event, and unfortunately have a much higher mortality rate, which we'll talk about. At the R. Adams Cowley Shock Trauma Center, which is a unique trauma center, about 10 to 11% of our admissions each year are in persons 65 years of age and older. Most of those individuals 75 and older are women, and the most common causes for admission are either a fall or a motor vehicle accident. Next slide. It's important to note that although we see about 10–11% of our total population at the Shock Trauma Center, and this is pretty much a national statistic when you look at trauma centers throughout the country, they account for 28% of all fatalities per year within those same trauma programs. And even more important, perhaps, in terms of future planning and resource utilization, is the fact that this 10–11% of this population uses about a third of all the healthcare dollars spent in trauma. Next slide. So not to belabor it, but there are two peaks that we look at when we start looking at the aging of individuals in trauma. The first occurs when individuals are between the ages of 16 and 29, and clearly this is more commonly due to motor vehicle injuries and violence, such as from firearm injuries. The second peak occurs during middle age. However, the fatality rates increase as we begin looking at older individuals, particularly over the age of 75. Next slide. Men account for the majority of trauma patients until around age 70. After age 70, women clearly overtake in terms of the numbers of individuals in a trauma center. Next slide. I'm going to show you just some depictions by graphics. For those of you, you can see the incidence by age here, with the peak occurring in the ages between in the 20s, 16 to 28 or so. Once again, another peak in middle age, and then once again, a little blip later on in life. Next slide. This one looks at fatality rate, and as you could see here, with increasing age, fatality continues to increase as a higher percentage. Next slide. This just divides up the fatality rate by men and women, with men having a higher fatality rate as compared to women. Next slide. So motor vehicle accidents are the most common cause of death from trauma through around age 80. After that, falls become the major problem that we see in trauma centers. Now, if we were to look at just the cost of falls, we'd see in America we spend about $19 to $20 billion a year dealing with issues of falls. Next slide. Close to 2 million people over the age of 65 are treated in emergency departments for a fall-related injury alone, and about 400,000 elderly people are hospitalized each year following that fall. Next slide. Of those people who do fall, about 20 to 30% suffer moderate to severe injuries that result in significant reduction in their ability to maintain their independence. They also increase their risk of premature death. Falls are the leading cause of traumatic brain injury and cervical fractures in older adults as well. Next slide. Annually, more than 180,000 older adults are injured in motor vehicle crashes, about 500 older adults every day. Of note, there were, in just a few years ago, in 2013, over 30 million licensed drivers over the age of 65. And this is about a 19–20% increase from only 1997. However, by the year 2030, it's expected that the number of elderly drivers will almost double, where a number expected close to 60 million will be what we're facing. Next slide. So motor vehicle crash deaths clearly increase, as I mentioned, as we get older. And per mile traveled, fatality crash rates dramatically start increasing at 75, with the highest incline beginning after age 80. Next slide. So elderly persons are more commonly the one hit by another vehicle. This is an interesting statistic. If you were to look at the insurance companies, you'd find that the elderly person, more often than not, in their accident report, reports that another car hit them. But the most common maneuver that led to the motor vehicle collision is actually the elderly person themselves making a left-hand turn across oncoming traffic, not being able to estimate how fast the car was going or be able to make that turn fast enough to avoid being hit. So, in other words, they oftentimes are the recipient of the benefit of that accident in terms of insurance claim, and it's often not reported as their problem. Elderly have fewer motor vehicle collisions per driver, but more accidents per mile driven. The second most frequent accident that older people have is entering a highway which traffic are running at fast speed. Elderly persons more commonly are the one hit, as I mentioned, And this presents, I think, an interesting dilemma that we all must face when we start looking at who should be driving and how to begin providing licenses and renewals for the driver as well. Next slide. We mustn't forget other causes of trauma. About 4% of trauma in the elderly is due to thermal injuries, burns, either from cigarettes falling on a blanket or perhaps a person with a cognitive deficit whose clothing catch fire on a gas stove. Approximately 1,000 or 900 to 1,000 people each year are killed in a homicide, and of over 500,000 reports of elder abuse annually. Now, this includes all reports of elder abuse, not necessarily those who we can prove actually are being abused. But the fact is we must include not only people who are actively abused, but also neglected. So if you include the 500,000, that does include both active neglect as well as passive neglect. Next slide. So when we look at the people over 65 years of age, and we talk about trauma being about 10–11% of those people in the trauma center over the age of 65, it's important to note that nationwide, approximately 13% of the population is over 65. And this indeed will be growing quite dramatically. By the year 2050, it's been estimated that around 20% of our population will be over the age of 65. And 40% of all trauma patients will be over age 65. The majority of our elderly population now are between the ages of 65 and 75. By the year 2030, 40, and 50, there'll be more people 75 and older of that older age group than 65 to 75. And as I hope to convince you, the person over 80 years of age is indeed different in terms of the physiological responses, how they can deal with a traumatic event, as compared to those individuals who we call the young old, the 60s and 70-year-old individuals. The total economic cost of trauma in people over 65, as I mentioned before, those who fall, about $19 billion is spent, but overall, over $30 billion is spent in America alone on trauma patients who are over the age of 65. Next slide. So elderly persons are a composite of what we call normal age-related changes, age-prevalent disease, a nonspecific or atypical presentation of illness. Whenever I see an older person, I think of them in this way, and I'll talk a little about this. So what is normal? And if it's normal, it's not something that we want to fix or treat or write a prescription for. Age-prevalent diseases are diseases that are more common than you would expect based on the simple percentages of that population. So if 40% of all people with hypertension are over 65 and only 13% of the population is over 65, we would say hypertension is an age-prevalent disease. Other examples would include heart disease, certain cancers, dementia, and so forth. Nonspecific and atypical presentation of illness is really one of the hallmarks in caring for the older person. And we think different disease states when we begin thinking about a differential, and we also think different processes. So an older person, for example, is having loose bowel movements. The geriatrician thinks about constipation, and once again, working that up. When we think of someone who has a change in mental status or a fall, we think of urine infections or perhaps medication toxicities and the like. Often diseases are non-specific in how they may present. Next slide. So what is the end result of age, and how does that impact on how we can handle trauma? One of the main things we need to be aware of is that as we get older, we have a decreased ability to deal with stress. This has been called homeostenosis, less of an ability to maintain that equilibrium phase. And that's important whenever we're giving medications, whenever we're giving fluids to an older person. We need to start low, go slow. We need to be extra cautious because that older person may not handle what we're doing in the same way. So if we drop a blood pressure perhaps too much, that older person may very well end up with a heart attack or stroke, whereas a younger person may have counter-regulatory mechanisms, be able to correct that blood pressure. The same in terms of hypoglycemia and other side effects of medications that we may give. There is a reduced regenerative ability and less reserve capacity as we get older as well. Pretty much every organ system loses cells with normal aging. We have a maximum number of brain cells in the first trimester in utero. And by the time you're finished listening to this webinar, you'll have less brain cells than when you started. But the fact is we have more than we need. We have a reserve capacity. But as we get older, we have less and less of this reserve capacity, and therefore, once again, that hypotension, that hypoglycemia, or that traumatic event may result in lifelong disability and decreased quality of life, much more so than it would in a younger person. A broken bone takes much longer to heal as in old age as compared to younger age as well. Next slide. Altered pharmacodynamics and kinetics is very important. We have changes in body composition. We double our body fat between the 3rd and 9th decades of life. Doesn't mean necessarily that people are fatter, though many people are, but we have a redistribution of our own body components. So medications such as psychotropics that are fat soluble may hang around much longer, leading to that a person with trauma having a change in mental status perhaps 12 or 24 hours later, much later than we would have expected in a younger patient. We have changes in our intracellular and extracellular fluid, and the volume of distribution of medications may also be affected, resulting in unwanted side effects. Decreased ability to respond and recuperate from injury, as I mentioned, and also to benefit from rehabilitation. And that's something that oftentimes fails to be something we think about. But with age, there's a decrease in muscle mass. Putting someone in bed from a traumatic event will result in a more rapid decline in their ability to get back to being rehabilitated as well. Next slide. Decreased wound healing. This was first described by Sir Francis Bacon many centuries ago, but the fact is this is held up to this current point. It takes longer to heal, a higher incidence of dehiscence of wounds in older populations, something we must look for. Increased susceptibility to infection. A reduced cardiovascular reserve. These are things that, once again, result in the older person being more frail, more vulnerable, and the physician and nurse and other staff needing to take extra precautions and also more observation. Next slide. Reduced extracellular and intracellular volume I've already talked about, but there's also a reduced hypothalamic response to changes in osmolarity. We have a decreased thirst mechanism as we get older, and therefore the older person may be dehydrated. They may be hypernatremic and not even say, gee, I'm thirsty. You can put the water next to the bedside, but they may fail to be thirsty and drink. And therefore, once again, we have to think about various age changes that may result in how that person is monitoring, is able to care for themselves and able to be part of their health care. We also know that there are changes in the adrenal response to changes in volume and electrolytes. There's an increased ADH and atrial natriuretic factor and a reduced aldosterone. These both predispose to hyponatremia in the older population. It's not uncommon for older people, particularly those over the age of 80, to maintain at baseline sodiums between 130 and 135. I like to get prior records of what people's baseline electrolytes and laboratories were so that we're not searching for some value that perhaps is unrealistic and different from what they were before their traumatic event. Next slide. That's particularly important in individuals where we're thinking about SIADH, particularly from head trauma, where their sodium may now be 28 or 29, and we're saying, wow, is this from the neurotrauma that they just had, or is this something that's not very different from their baseline, or perhaps they got too much free water in the emergency department. We know there are changes in posture and muscle mass, joint function, neuromuscular ability. The increased risk of falling is much more dramatic, and our ability to rehabilitate older people may be impaired. There's a decreased ability to right oneself after a fall, resulting in a lot more C-spine fractures and traumatic brain injury than we otherwise would see from a fall in a younger population, whereas most younger people would have a Colles fracture or wrist fracture. The older person may very well be more predisposed to developing a cervical fracture. Common age-related comorbidities include low levels of vitamin D, B12, folate, abnormal thyroid function, and these all have been associated with not only a change in cognitive function now, but also an increased risk of falls. And this is one of the things that we look at. We do have a geriatric panel, which I'll share with you in a minute, and this does indeed include all of these values we mentioned here. These are things that often escape us in terms of our thought process when we're looking for causes of falls. Next slide. Curvature of the spine, as seen in osteoporosis, is a real risk in our older population. I look at shoes when I see patients who are prior to coming to a trauma center, because that little bit of heel that an older person may be wearing may shift their center of gravity forward, predisposing them to falls. So anybody in a trauma center, when I talk to them, I also try to provide them with counseling when they do go home, how we can prevent that next fall from occurring. And once again, a good GAIT assessment, physical assessment in the rehabilitation center may very well help prevent that future fall. Reduced protein status may impair immune function, may result in a decline in muscle mass, and once again, impair our rehabilitation potential. Age-prevalent dementia is something that we see a lot listed in the chart, and when we finally are able to evaluate our patients, oftentimes it indeed is due to a hearing deficit, or perhaps the traumatic brain injury itself, or perhaps some confusion from medications that the patient was put on. So I avoid labeling patients in a trauma center as being demented unless there is a clear history behind it. And we'll talk more about dementia and how we can assess it in a few minutes. Next slide. Dementia does predispose to delirium, particularly in the trauma center, and we need to be aware of that. All 5 senses change with increasing age. Hearing and vision are key factors that may make it harder to care for the person in a trauma center, make it harder for them to be aware of their surroundings and participate in the care and recovery from that traumatic event. And as I mentioned, as we get older, delirium indeed becomes a greater risk. There's a greater prevalence of dementia, which predisposes, immobility in itself, sensory impairment, sleep deprivation, infections, dehydration, polypharmacy, and many other factors. So delirium is something we always think about and think about strategies to avoid in that older person who has had a traumatic event. Next slide. So what is geriatric assessment and when do we do it? Well, we have at the RMS Cowley Shock Trauma Center a geriatric consultation program where we see the older individuals and work alongside the surgeons, the orthopedists, the neurosurgeons, trying to maximize quality care. In general, a geriatric assessment is a multi-dimensional process, and it can either be done by a single individual who's experienced as in dealing with all of these issues, or as a team of professionals, physicians, nurses, psychologists, social workers, and the like, audiologists, rehabilitation specialists. It's designed to assess an elderly person's functional ability, physical health, cognitive and mental health, and socio-environmental situation. Unfortunately, in many patients in the trauma center, we're unable to assess all of these aspects, but I'd like to review for a minute what is a geriatric assessment, next slide, and how we might proceed, at least in terms of making the decision, what we can do in terms of our assessment now, or what perhaps needs to be obtained from prior records, or what we may need to wait for when the person is more stable, perhaps in a rehab center or later on. The American College of Physicians, recognizing that it's not always possible to have teams of health professionals, put together a list of 10 aspects that they felt all internal medicine or family physicians should be aware of when assessing the older person. And I look at these in all of the trauma patients that I am providing a consult on. These are big impact items in terms of quality of life and the ability to lead as independently a functional state as possible. Vision and hearing, key factors we'll talk about. Upper extremity function and lower extremity function. Continence, both fecal incontinence and urinary incontinence. Mental function. The instrumental activities of daily living. Those include the nice-to-do things such as cooking, dressing, shopping, bathing, and the like. The basic activities of daily living, which include mobility, transferring, toileting, and feeding. The most important aspect of whether or not any patient will be able to be at home with minimal family support is the ability to transfer. If an individual is not able to transfer, most family members feel insecure and uncertain about leaving their loved one home alone and burn out in terms of their own quality of life. So we do try to put a focus in terms of rehab on the ability to independently transfer. Environmental hazards. I always use the opportunity to talk to families about ways to structure their home if the goal is to get the older person back home to prevent a future traumatic event. And social supports. Who's available? Who needs to be available? Is there a rapid response pendant available? Things of that sort to make it easier for the person to live independently or with minimal support. Next slide. So in a few minutes, I'm going to describe the 10-minute geriatric assessment. This is, once again, only one slice of time, and you need to compare the results to baseline status prior to that traumatic event itself. So you can establish what are some of the new findings resulting from trauma versus baseline limitations. Not everything can be done on everybody, but once again, this is a thought process I go through in terms of, can I make the following assessment or can I not? Do I need to come back later on in the hospitalization to do so, or should we best leave this to rehabilitation or later on? Next slide. I believe these are important as part of the armamentarium. So the first thing we need to be aware of, this is a mnemonic. It was developed by a colleague of mine from prior experience called Dr. Frederick Sherman, and I'd like to take you through this. Next slide. So the first is, the mnemonic is going to be called Deep In. D stands for dementia, depression, and drugs. Next slide. Eyes. Next slide. Ears. Next slide. Physical performance, falls, it's a little cutesy, but that's part of the mnemonic, and psychosocial. Next slide. Incontinence, and next slide, nutrition. So deep in. And in a few minutes, you should be able to provide the assessment. These are key factors that are important in terms of assessing the older person, in terms of their functional state and what needs to be done to get them back in a restorative mode. Next slide. And the next one. Next slide. Okay. So dementia. The key thing to remember is that many patients do have a cognitive deficit and nobody's aware of it. And there are people who are inappropriately labeled as having a cognitive deficit when they indeed do not. So physicians often fail to evaluate, often fail to document. Families may be covering, workers, colleagues may be covering, and this is something we always need to think about. Although only 5% or so people over 65 have a dementia, over 20% of individuals in their 80s, 20 to 25%, are able to be diagnosed as having a dementia. Next slide. There are many things that you can do to screen, and I think it's important to say to yourself, what threshold do you want in terms of your screening? The Folstein Mini-Mental is considered to be the highest yield, and the one that we use as the gold standard, with a score of 26 or greater, being that which we look at for someone who is completely cognitively intact. However, if you have an individual who has not had a cognitive impairment by history, does not have a traumatic brain injury, and you're just trying to provide an assessment, the following are perhaps a little less comprehensive than the Folstein Mini-Mental, but oftentimes sufficient at the bedside. Now, this involves a 3-item recall. It first assess attention span by asking the individual to say back 3 things that you're going to ask them to recall in a few minutes. I always put a number in. So I give, for example, red, 7, and pencil. I ask the patient to repeat it, and if they are able to repeat it, I then have a tested attention span. I then go on and talk about something else, and 5 minutes later I go back and ask them to repeat those 3 things that I gave them to remember. And if they can repeat all 3, very low likelihood that they have a cognitive deficit. If they can only recall 2, depending on your threshold and what you're looking at, they probably also are functionally cognitive intact. If they can only do 1, I then go on and do either a full mini-mental or some other assessment of cognitive function. Next slide. Another assessment that people can do is called animal naming. And that's asking individuals within 1 minute to name as many animals as they can. And I don't mean blue bear, white bear, green bear, but specific animals that they can recall. Next slide. The average individual with cognitive function intact should be able to recall 18 animals within 1 minute. Less than 12 is considered to be abnormal and should indicate another test is warranted. Next slide. Next slide. Next slide. Okay. The clock completion test is another test that is often used. The 4th quadrant is the best predictor of cognitive function. So on the next slide, you'll see that individuals who are unable to put the numbers, you ask the individual to draw a circle. You say, we're going to ask them to put the numbers on a clock face, to draw a circle and put the numbers on it. If they get any number wrong within any quadrant, they get 1 point. But the 4th quadrant is the most specific for predicting dementia, with a sensitivity of 87% and a specificity of 82%. I combine several things, something called a mini-cog when I evaluate cognitive function in most of the older patients I see. And that is a test of orientation, person, place, and time, the ability to repeat back 3 objects, a test of attention span, the short-term memory testing by giving the 3 objects, and then a clock draw test. These things alone, if you just look at that, have over a 92% sensitivity and take a much shorter time to do than the full Fulstein mini-mental. Next slide. Okay. Just to reiterate, dementia is a significant problem in older individuals, 50% due to Alzheimer's disease, 25% due to multi-infarct dementia, and 25% due to treatable, preventable causes, as you can see on this mnemonic called dementia, with drugs, eyes and ears, vision and hearing deficits, metabolic disorders such as hyperglycemia, hyponatremia, pseudo-dementia, which correlates with a depression, nutrition and normal pressure hydrocephalus, tumors and trauma, infections, and alcoholism and atherosclerotic. So these changes here account for approximately 25% of dementia. Next slide. It's important to sort out what's due to the traumatic event versus the condition that we're looking at on that slide. Depression. Although depression is not present in everybody, it's something that we look at very commonly in a person who's just undergone trauma, who perhaps may have family members as well in the hospital with traumatic injuries as well. The 5-item geriatric depression scale has a sensitivity over 97%, and this is indeed considered to be the gold standard for evaluating an individual in the elderly age group for depression. I'll show you that in a minute. And this is higher than the former assessment scales that were used that included 15 or even 30 items. However, as a screen, the single question, do you often feel sad or depressed, has an 85% sensitivity, and perhaps in most individuals is sufficient for screening. Next slide. For those individuals that you feel necessary to do the 5-item scale, this is it. Are you basically satisfied with your life? Next slide. If you say no, you get a point. Do you often get bored? Next slide. Yes, you get a point. Do you often feel helpless? Yes. Next slide. You get a point. Do you prefer to stay at home rather than going out and doing new things? You get a point. Do you feel pretty worthless the way you are now? Yes, you get a point. 2 or more points are highly correlated with depression and deserve further evaluation and treatment. Next slide. We always look at the medications that people are on. Are they on any of these medications such as the anticholinergic medications? Medications that have a high anticholinergic property to them. The antispasmodics, are they on benzodiazepines? But once again, they may have some non-prescription medication, alternative remedy, an herb that may also be affecting their mental state as well as their general health. So medications are always an important part of a geriatric assessment. Next slide. Hearing. It's important to remember that high-frequency hearing loss is a normal part of aging. It makes it more difficult to hear consonants and to hear speech in a way that we are accustomed to. So many times older people would say, why do people mumble all the time? Well, it's not that they're mumbling, but indeed the fact is that younger people are talking the way they always did, but the older person is not hearing the same as they did when they were younger. And it's not that you don't hear the high-frequency sounds, but they often provide a distorted sound that interferes with hearing when an individual is in a noisy environment. So yes, we can do a whisper test as shown here, where we stand around 12 to 18 inches behind somebody, we whisper 4 numbers, and we ask the person to tell us what they heard. And in a quiet environment, they may very well appear to have normal hearing. But the fact is, now you put them in a busy trauma center with other sounds, you put them in a supermarket or a bingo hall, and indeed, the older person does not function. So the questions really should not be, how did they do on the whisper test, but how are they functioning in an environment? Now, it's important to remember that while we use these pocket talkers, oftentimes in people who cannot hear, they will magnify all sounds across all wavelengths, and mumbled speech may just be louder in that mode of evaluation. So the fact is we can try it and see if it helps, but there's no substitute for getting the hearing aids that the person may be using at home into the trauma center, putting them in their ears and allowing them to hear with specially adapted hearing devices. Next slide. And this just tells you about the whisper test. There are special audioscopes and other things that people can get as well, but this is a simple way of testing. But once again, they falsely overestimate the ability to hear in noisy settings. Next slide. Next slide. Okay, eyes. Functional vision is very important. Is the person able to read? Be aware that macular degeneration is the leading cause of blindness in the elderly. However, glaucoma is the second leading cause, and glaucoma presents as a peripheral vision loss which works its way forward. Macular degeneration begins as a central scotoma, works its way out. So simply using a Snellen chart may very well be misleading unless the person is forced to read the Snellen chart directly in front of them. Asking the questions, are they having trouble with their driving, watching television, reading, putting a newspaper in front of them, asking them to read certain words is also a very good way of assessing visual function. Next slide. Okay, next slide. Physical performance is difficult to assess. I put it here only for completeness, and perhaps for those of you interested can refer to this. This is something that perhaps is more relevant in those individuals who already are part of a rehabilitation program, but early on it's something we want to think about. What was their function before they came into the trauma center? So at least we have our baseline. Were they using a cane or a walker? Were they using a wheelchair? If you have the ability to assess them while they're in the trauma center, so much the better in terms of they using those items correctly. But the fact is that if they're there in the trauma center, we may need to start with a new baseline and work our way forward. We do know there is a correlation with physical performance and prognosis for their ability to live independently. Next slide. Next slide. Okay. Next slide. What are some risk factors for functional dependence? Shown on this slide: cognitive deficits, individuals without the financial resources, those with less education, older age individuals. Clearly, as you can see here, there are many risk factors that we evaluate in terms of their functional dependence later on and how well they will do in a rehabilitation program. Next slide. Now, we do know that even minor injuries, patients who come to the emergency department, have a lot more functional impact than we otherwise thought. There have been several studies that have come out fairly recently that show that even minor injuries have been associated with at least a 15% functional decline as far out as 6 months later. We tell the emergency room staff and medical students that when someone shows up in an emergency room, that yes, it's nice to say you have no broken bones and no injuries that are life-threatening and require further treatment, but they should be advised to see their primary care physician in a short period of time. Often it's the urinary tract infection that they didn't even know they had that may have been causing the fall, or perhaps it was a change in their medication or medication toxicity that perhaps didn't appear obvious at that moment, but would continue to cause falls and trauma, and we need to be aware of it. Next slide. It's been shown that 50% of people over 80 who fall within 2 weeks will have a change in their medical condition, and that is something that we need to follow up on. Factors increasing the risk of functional decline is using walking aids, medications. The more medications, the more at risk they are. People who need help in their instrumental activities of daily living, and those whose prior physician assessment did document a decline in their functional status. Next slide. So in individuals, there are certain things for people who are falling that are looked at. This is a study done by Sawar, and they looked at a timed up and go test where an individual walks 10 feet. You record how fast they're going. Looking at depression scales, they have a modified scale that they looked at. Times per week the person leaves home. And as you can see on this slide, there are things that can be looked at in terms of who will not do as well in terms of function following a traumatic injury, even if it's minor, requiring an emergency room visit. Next slide. So what are the predictors of being dependent following a traumatic event? Those people who live alone, people who are not currently married, and those people with dependence on more than 4 instrumental activities of daily living. the data shows that these individuals will not do as well in their independent state following a traumatic event. Next slide. A lot of it is common sense. One of the things that we do in terms of assessing function is how fast people walk. And being able to walk, as I said, that time test is very important as an indicator for frailty and how well people will function. Walking speed also has been correlated with mortality. So if an individual is walking 10 feet back and forth, we know that a gait more than 11 seconds in doing that has been highly associated with increased fall risk and increased mortality. Being able to do 3 chair stands in more than 10 seconds is also considered to be a functional impairment and one that highly correlates with dependency and activities of daily living. Next slide. An individual should be able to reach at least 7 inches. Less than that increases your risk of falling. And once again, we don't do this on everybody in a trauma center, but these are things that constitute a part of a geriatric assessment, and these are tools that should be in your hands so that you can do the evaluation if you feel appropriate. Next slide. Many reasons why people fall. I think common sense is often one. People walking on ice, doing strange things, climbing up ladders, many examples I can give of why people fall, but clearly we must rule out significant medical conditions from aortic stenosis to orthostatic hypotension to TIAs, strokes, cardiac arrhythmias, and the like. So it may be as simple as somebody drinking too much or falling on a wet floor, but also a fall may be the harbinger of something much more significant, and we evaluate individuals who fall for all of these as well. Next slide. The Morse fall scale I included just for completeness. I'm not going to go into it other than to say it's available here and to say that in the hospital there is a scale called the Morse fall scale, which gives you a feeling of the person's increased risk of falling again upon discharge from the hospital. So we could just go through that very quickly in terms of the slides. Next slide. Okay, next slide. This is just a listing of what it is. People can refer back to it if they would like. Next slide. Next slide. Okay, incontinence. Can we go back one slide, please? Incontinence. 2 questions. In the last year, have you ever lost your urine and gotten wet? Have you lost urine on at least 6 separate days? If yes, you have a high positive predictive value, and this correlates very significantly with special assessment instruments. So a simple question can guide you. Many people think it's normal to be incontinent, but the fact is they may have a treatable condition, even a urinary tract infection that may be treatable. Studies done in medical students have shown that putting on an adult pad with the wet feeling, the hot, warm, wet feeling, actually stimulates the sacral roots and results in an extinguishment of the feeling that you have to urinate, resulting in a self-fulfilling prophecy of urinary incontinence. So the fact is, adult pads should be used only when essential and should not be left on patients unnecessarily. A toileting regimen would be the preferred treatment. Next slide. I'm going to skip this one. Nutrition screens. There are many available. We use the mini nutritional assessment, but once again, nutrition is an important part of the rehabilitation process. Individuals need to be evaluated in terms of what type of diets they can tolerate. Is there a problem with their teeth, dentures? Are there any medical conditions we need to consider, such as hepatic failure, diabetes, and the like? And once again, try to provide an assessment of, does this person need small, multiple meals throughout the day with nutrient-dense foods, such as is preferable in individuals with cognitive deficit, or can they eat a normal diet? Next slide. Okay, and this is the mini nutritional assessment. Once again, I'm going to let the listeners refer to this on their own, but there are specific questionnaires that can evaluate, next slide, an individual's risk of being malnourished. Points are assigned, and at the end, once again, you can establish if someone has a normal nutritional status, at risk of malnutrition, or malnutrition. This scale was developed by Dr. Nestle at Cornell New York Hospital in New York. Next slide. Many causes of malnutrition, as you can see on this slide, but once again, it may very well be a cognitive deficit, an inability to be able to go out and shop appropriately, be able to afford food, and the like, depression, swallowing difficulties, medications, which may give a bad taste to food. So once again, this list is called Meals on Wheels. It's important for people to refer to and make sure that they think about whenever they're assessing nutrition. Proper nutrition is essential. We look at prealbumin in individuals. I'll talk more about that in a minute. We try to provide an assessment of their nutritional status coming into the traumatic event and how they're doing following the traumatic event and how we may need to modify diet appropriately for them. Next slide. So weight loss, once again, many reasons, but clearly having a traumatic event is high on the list for being at risk of nutritional deficiency. Next slide. So we at the R. Adams Cowley Shock Trauma Center do have a geriatric order set. It requires that the physicians make a check. It gives you a CBC with differential, a urinalysis, particularly because of the fact that even without symptoms, many older people do fall as a result of a urine infection, and something that may also impact on our ability to recover from a traumatic event. We look at the 25-hydroxy-vitamin D level, not just when we have an individual with a fracture and we're interested in getting proper bone healing, bone metabolism, but the fact is 25-hydroxy-D has now been implicated as essential for proper cognitive function and proper neuromuscular function. The normal level of 25-hydroxy-D, which is a storage form of vitamin D, is between 30 and 50 nanograms per mil. B12 is essential in terms of not only hematologic function, but also neuromuscular and cognitive function. And whereas young people, the level is, the upper limit of normal is in the 200s, it's been considered with multiple studies now showing that people 80 years of age and older do better from a cognitive and neurosensory point of view when their B12 is greater than 300 picograms per mil. Folic acid level, once again, is checked, metabolic profile, free T4 and TSH, electrocardiogram, and a prealbumin. A prealbumin of greater than 20 is highly correlated with a normal protein store. When individuals come into a trauma center, however, we need to be aware that prealbumin is also an acute negative phase reactant, and therefore individuals may have a lower prealbumin following the traumatic event than they had immediately prior to it. So what I look at is if it's greater than 20 coming into the trauma center on an admission, I recognize that there probably are sufficient in their protein stores, and it may not be as quick to say we need to get them going in terms of supplements or nutritional repletion. Those individuals who have prealbumins less than 12 probably are coming in protein deficient. In between, it's on an individual basis whether or not they are adequate in terms of their protein stores and the acute injury has resulted in a lower value, or whether or not they may have a deficiency. So we come back and look at it. Fortunately, prealbumin has a half-life of 48 hours. As we begin repleting nutrition on that person, we can see changes quite rapidly as compared to albumin levels, which have a 20-day half-life and a lot more variables in terms of causing ups and downs. Next slide. Now, there is a major focus. If you could just go through the slides so that all of these highlight up for us, please. I think the important thing for us to remember is that we have a new entity, and I'm going to take you through this quickly, and it's called frailty. We used to say people over 80 were frail. That was a term we used. But we now recognize this as a subset of elderly persons who are considered to be at greatest risk. It's now considered to be a syndrome associated with weight loss, fatigue, and weakness, and it's a prognostic factor for poor outcomes. Let's look at it. Next slide. If we could just go through these. So these individuals are the highest risk for poor outcomes. They tend to be in nursing homes more frequently, higher mortality rate, they fall more frequently, they have more iatrogenic problems, and slowest recovery rates. Next slide. It's been said that these individuals have an abnormality that results from a cytokine overexpression and hormonal decline. And I'm going to talk to you a little about that as we go on. It's thought to relate to the aging process. Next slide. This was the original description by Dr. Linda Fried and her collaborators. It was felt that individuals who had 3 or more of the following: weight loss, weakness, exhaustion, slowed walking speed, and low activity met the criteria for being identified as frail. Next slide. This is another way of looking at it. I'm going to leave this to the listener to look at their own leisure. The Europeans looked at this data and they said they prefer to have descriptions. And this is something that you can do even asking family members to try to see whether or not the person who's now with you in a traumatic, after a traumatic event actually was frail coming into it. So for example, it says here, in the last month, have you had too little energy to do things you wanted to do? Yes or no? That's a question you can ask the family. Has your loved one had too little energy to do things that they wanted to do? And so forth and so on. Next slide. These are how it's assigned, and this is another way of evaluating for frailty. Next slide. So frailty, if you were to look at the various studies that have been done in large populations of elderly, you'd find that somewhere around 7% of individuals over 65 years of age meet the criteria for frailty. Next slide. And please note that these individuals have a higher rate of congestive heart failure as well. They have more falls. They have worse mobility. They have worsening in their activities of daily living and a much higher rate of mortality. Next slide. We know that individuals who are frail have 20 times more likely requirement predicted for requiring subacute care following an operative procedure, and are 4 times more likely to die from post-op complications than those similarly aged individuals who are not viewed as being frail. So doing a prior assessment, trying to sort out who was frail coming into the traumatic event, indeed may have some predictive value as well. Next slide. This just shows you that these individuals tend to have abnormalities in their clotting and inflammation. Next slide. Higher rate of inflammation. This shows you the clotting. Next slide. Higher risk of having thrombosis. They also tend to have higher blood sugars, insulin resistance. Next slide. Higher cortisol levels and lower anabolic steroids. Less ability to heal. Next slide. So in summary, frailty is a chronic inflammation and endocrine dysregulation present in around 7% of individuals in the elderly age group, and something that we try to look at in terms of predictors of how people will do following a traumatic event. Next slide. And this just shows you another depiction. You can look at it later on, but the fact is this has been studied and it's now considered to be an actual syndrome and not just a term. Next slide. So in the next few minutes, I just want to talk a little about a problem that we identified a few years ago, and that was the post-traumatic stress disorder in the elderly person who has had a traumatic event. A lot of times we don't think about this in the elderly. We often think about it in individuals who've been in combat or individuals who've had traumatic injury from rape or other issues. But the fact is the elderly in a trauma center are at great risk of having post-traumatic stress. And the important thing to remember, it can become a chronic problem over their lifetime, and you may now just be seeing a reappearance or an exacerbation in, later on due to this traumatic event. Next slide. Symptoms of post-traumatic stress may manifest after witnessing or experiencing an overwhelming traumatic event, a personal injury to themselves, an assault, an abuse, or some type of natural disaster. Traumatic events during youth may have recurring symptoms that affect late life, and therefore having a history from that person in terms of their prior exposure to trauma may become important in terms of predicting who will have a post-traumatic stress disorder. Next slide. New onset in the elderly needs to be recognized early if we're to try to begin treating it effectively. And it's been said that more than 10% of men and 6% of women with post-traumatic stress reported 4 or more types of trauma during their lifetimes. Next slide. More frequently, particular issues for the elderly are more frequently hospitalized, sustained traumatic injuries from falls and motor vehicle injuries, and a higher number of lifetime stresses, increasing the risk of post-traumatic stress as compared to middle-aged or younger individuals. Next slide. A history of prior trauma, especially childhood abuse, highly correlated with late-life post-traumatic stress disorder. A family history of anxiety disorders, persons with poor interpersonal interactions, or people who are very negative, these individuals are considered to be at greater risk. Next slide. The greater the intensity of the trauma and duration of the trauma, once again, the greater risk of developing a post-traumatic, and also the unpredictability of it, the perceived lack of control over one's environment, the failed attempts to avoid the injury are also thought to be predictors of who will develop a post-traumatic stress disorder. Next slide. So predisposing factors, once again, should be looked at. Does the person have a history of being a Holocaust survivor, prisoner of war, being a victim of sexual abuse or rape or other violent crimes earlier in life, combat experience, and so forth? And then that motor vehicle accident or fall may not seem so significant to the casual observer, but when putting it all together may increase the risk that this person will develop a post-traumatic stress disorder. Next slide. We know that elderly with post-traumatic stress disorder tend to have more memory problems, have more affective changes as well, and more anxiety and depression. Next slide. Characteristics that appear to protect against post-traumatic are social support, humor, openness to change, flexibility in thinking, and optimism. Next slide. Things that should all be encouraged. So good communication. Trying to reassure the individual, talking in comforting tones, doing what you can to prevent delirium, frequent orientation, comfort measures, providing nutrition and hydration have all been shown to be helpful. Next slide. But the early recognition appears to be key. Pain control, and as I mentioned, judicious use of medications in anyone, but particularly in this population, is very important. We like to use stress reduction techniques such as teaching people to meditate, counting breaths, Reiki therapy, and the like. But there comes a time when certain individuals will need psychological counseling and therapy, and that's something that should be done promptly as needed. Next slide. So in summary, trauma in the elderly is something that is going to be increasing quite dramatically as our population will continue to age from its current 13% to over 20% of the population being over 65 years of age, and in the next few decades, 40% of all trauma patients being in that elderly age group. Normal age-related changes in age-prevalent illnesses do alter the response to traumatic injury and their ability to recover. It's important to assess an older person's functional capacity prior to, so we have a baseline, and also after the trauma, and try to work as much as we can with social supports and family to trying to optimize quality of life and getting that person back to their baseline state. So I'd be happy to answer any questions that anyone may have, and I hope you found this kind of different type of presentation from a geriatrician's point of view helpful in your thinking about older individuals who have had a traumatic event. Thank you.
Okay, so if anyone has any questions, we don't have a lot of time, but we have a minute or two. I did not see any questions. But if you have a question, feel free to type it in the box. Oh, there's one. Oh. I have a couple of comments that that was awesome presentation. Thank you. Here's one question. What is the model at your center? Multidisciplinary? How are assessments completed, and with what interval?
Okay. Well, good and bad. The good is that I'm available. I see all patients over the age of 75 and anybody between 65 and 75 as requested. I have seen many individuals who are younger, but the fact is that we begin with my assessment. I work with the nurses and the doctors and so forth. Our plan is to have a team. However, at the current time, I work with the existing on-floor social workers, nurses, therapists who are there. It was decided that we originally wanted to open up a special geriatric trauma section, but our program is very unique, and we have individuals who have very difficult to treat orthopedic problems, so we have an orthopedic floor dealing with that. We have very difficult neurosurgical complications. We have patients who come from really 4 or 5 states surrounding us by helicopter. We're a trauma center, regional trauma center. The military received training at our site. So the eventual goal would be to have a team, but it's a team without walls. And I provide assessments initially and then as needed on a case-by-case basis.
Okay. How can we get the attention of the administration to beef up this specialty service for our patients? Are there any tactics that worked for you?
Well, I think our administration from the top down felt that it was something that was missing, having the geriatrician's perspective in providing care because of the surgical intensive nature of the medical care at our trauma center. So I think if you could once again get the surgical people to say, wouldn't it be nice to get that medical input, that would go a long way. But our chief surgeon requested and recognized that this was essential. And our chief surgeon is also the head administrator for the program, and therefore, you know, we were able to move ahead with it. But I think if you just look at the demography on it and look at the economics of it, I think I would focus on that. That at our place, 1/3 of the cost, the entire cost, is spent on dealing with the 11% of that population, and this is a number that will only grow. So perhaps from an economic point of view, you could argue that that would be beneficial.
Okay, and we are running over on time, so we are going to go ahead and end the questions. I think there may have been a couple of questions about making the presentation available, and with Dr. Gambert's permission, I will email all the PDF of the slides to everyone that's logged in today.
That's fine.
And if you have any specific questions that didn't get answered, feel free to respond to that email I'll send out, and I'll try to get that on to Dr. Gambert to answer those questions for you. So thank you for your presentation. Attendees, thank you for your time, and I hope you guys have a great day.
Thank you.
Thanks.